Hi, this is Prystowsky, and welcome to another episode of EP on EP. What an absolute delight it is for me to have my guest today, Dr. Daniel Singer, who's a professor of medicine at Harvard University, and really the person who I've been reading your literature for years on the topic we're going to discuss, which is what to do with device-detected atrial fibrillation. So, Daniel, welcome to the show. Let me ask you the first question. Can you frame the problem for us? The issue of finding AFib. Let's start actually with implantable devices, then we'll move to maybe the newer ones.
Right.
Tell us about what we actually know.
So let me just frame the issue. From the original anticoagulation trials, there was evidence that people with paroxysmal AF benefited from anticoagulation, and the guidelines say if you have paroxysmal AF, you should get anticoagulated. But we've learned over time that people with paroxysmal AF have less stroke risk than those with persistent AF. And now with devices that can pick up subclinical AF, we find that there's an extreme level of burden that is quite low burden, much less than was in the original trials. And so the question there is, do these people face increased stroke risk, and will they benefit from anticoagulation? And there are several studies and emerging more studies that address this issue. One of the interesting findings from the ASSERT-1 trial, the ASSERT-2 trial, is that if you implant a device, a monitoring device in people who are, say, 75 or so, 30% of those people over 18 months will show some evidence of AF, some evidence meaning greater than 6 minutes. There are fewer and fewer people who have 24 hours. From ASSERT-1, we now know that the stroke risk faced by people with subclinical AF is a function of how much AF you have. And they didn't see increased, statistically significant increased risk until you got to an episode of 24 hours or more. The other studies include the TREND study, and the TREND study showed that if you had more than 5.5 hours in any given day of atrial fibrillation, you faced a doubling of your stroke risk. Now, the actual stroke risk was not that high. It was in the 1% to 2% per year range, lower than if you had persistent AF. There are additional studies that are coming online. So, for example, Rod Passman and Paul Ziegler from Medtronic recently published a study where they linked the enormous Optum insurance databases with CareLink, and they found that your stroke risk was a function of your CHA2DS2-VASc score, and your duration, the longest episode that you have in any given day on the Medtronic devices. And the people with the highest stroke risk were at the highest CHA2DS2-VASc score and the 24-hour
So that's what I wanted to get at a little bit as a clinician who sees these patients all the time. When you've done a great job reviewing what we know, and it's confusing to a clinician like myself, because one study says 6 minutes in your risk, another one says 24 hours. And neither of those actually talk to the burden, which you just brought up as important. So this is confusing for the clinician. Based on what you now know, just reviewing all the literature, what advice would you give to us? As, for example, is there a burden more than just one episode? I mean, does it matter if you had X number of hours over time, or is it more important to have a 24-hour episode? How do you interpret
most of the studies address the longest episode. They don't integrate it over time and say if you have 30 days of AF, it's more than it gives you a higher risk than if you have one long episode on one day. The TREND study actually showed that about 11 hours over the course of a month increased your risk.
See, I didn't mean to interrupt you, but that's kind of the my gestalt, right or wrong, is that each episode of AFib people have does something to the endocardium. I mean, maybe it won't cause a clot necessarily, but over time, are there changes taking place that make that atrium more thrombogenic? Right.
So I don't know that TRENDS data did address that a little bit in their secondary analysis of the 30-day burden. There's the KP Rhythm study, which is looking at symptomatic individuals who are wearing a Zeo patch. And there, it was percentage of time over the 2 weeks of wearing the Zeo patch. Not the longest episode, but the percentage of time.
Right.
So, AF burden, amount of AF, it can be measured in so many different ways.
Right.
I would say, though, at this point, what we have good evidence of is that short episodes, and what's a short episode? Less than an hour. Short episodes, in and of themselves, don't pose much stroke risk. But as you get longer, and certainly at 24 hours, you're facing an increased stroke risk. Now, for the individual patient that you're facing, let's say they have, an hour or a little bit less than an hour. You can reassure them about that episode, but what about it's going to be down the line,
Right. That's the worry.
And that's the worry. And so the question is, do you just watch very carefully? And then, if you collect more information that the episodes are longer, then you act. If you don't, you do have, you have to worry about the harms of anticoagulation.
Right.
Where we have benefited from the novel anticoagulants. There's much less intracranial hemorrhage risk, so the really devastating outcomes have been reduced. But it's not trivial to be on anticoagulants.
So let me ask you this, though. I just had a patient I saw in the office this week, and she's a CHADS VAS score, I think it was either 4 or 5, and she had about a 2.5-hour episode. She actually has an ICD. So I called her and brought her into the office, and I went through the usual discussion of potential risk. But what I couldn't tell her at this point, and I want to get your feeling for what you think. I know there aren't the data there, but you have such a knowledge in this field.
Right.
What's an appropriate thing to tell her? I will tell you what I told her was, you could be, I think you're at risk.
Right.
And I can't actually tell you that studies have been done in folks like yourself, but here are the other studies. And I just talked it out with her, but what is that reasonable? What should we be
Sure,
doing?
that's very reasonable. I mean, in the absence of randomized trials, there are, by the way, at least 3 randomized trials that are ongoing that we should hear from. But in the absence of randomized trials, we're just trying to take observational data, talk about stroke risk, and infer whether anticoagulation is going to benefit. And there are lots of people, and you look and you make a sense. Is this person falling? Do they have other risk factors for major bleeding? If not, and you talk to them and they really, really don't want to have a stroke, and most people are like that,
Right.
but some have fears of bleeding
Yes.
that counteracts that. This is shared decision making.
Yeah,
In the absence of hard data, 2.5 hours is getting long.
Yeah.
And then obviously you want to watch carefully. But
So with all these studies that you've reviewed, and we're going to get into the wearables in a second.
yeah.
Do I use 6 minutes? I mean,
So
do
let
I
me
use 15 hours?
I
Do
know
use
you're
a
asking
day?
me the crucial question.
I don't
This
know.
is the crucial question, and as we discussed before, we're going to have tons of people who are going to have 6 minutes of AF on their watch or on another wearable, and they're going to come to their primary care doctor, and that primary care doctor is going to send them to you,
me, exactly.
and you're going to have to be Solomon,
Yeah.
and so I think 6 minutes in and of it. The problem with the cutoffs of greater than 6 minutes that were originally touted as raising stroke risk is that greater than 6 minutes included a lot of greater than 24 hours.
Right.
So
it's a mixed bag.
it's a mixed
Yeah.
bag. You want to see mutually exclusive categories of AF burden. And I think, trends, for example, showed that if it's in any given day, if it's less than 5.5 hours, your risk isn't any higher. Now, they're small numbers of events. These are not powerful, powerful studies. I think very brief episodes, and 6 minutes would be very brief. I'm saying arbitrarily the 1 hour cutoff. I think less than 1 hour, and there isn't anything more down the line.
I usually watch.
Yeah.
I'm actually a 20-minute guy, and I don't even ask me why, because I did that. I sort of cut a tweener for no reason, and it really was just my own observations. Following people for years and years and years, I found that most people who tended to have longer episodes had something at least 20 minutes at one point.
Yes.
It was just It was just my own. So, a small amount of time we have left. Let me ask you this. The wearables.
Yes.
They're driving us all crazy.
Right.
I mean, whether it be a watch or something you put on your phone or whatever it is. Any advice to the community out there on what we're supposed to be doing with these people?
Well, I mean, the first thing is to know whether it's AF or not.
Right. So, let's
So
say,
they're not perfectly accurate, that's for sure.
Okay.
The second is it's exactly the same question,
Yeah.
which is how much of that AF puts you at high risk. And you do have to put together their background risk, their CHADS-VAS score, if you will,
Right.
plus. But if you get somebody who's CHADS-VAS 2 or 3, and they have a couple of hours that you then validate somehow with a
Right,
patch or
I was
something.
going to ask you that. My current approach is if they pick it up and I see it and it's really AFib, I then follow up with several weeks of monitoring. 'Cause
Yeah.
just all the things you brought up, right?
Yeah.
That's reasonable, right? To see, are these a 40-second episode or are these
Yeah.
2-hour episodes?
Right, and also, well, that if you have it on a watch, you'll know how long the
Right.
episode is. But if you have an individual patient where you have validated that what they're picking up on their watch actually is what you pick up on a good electrocardiogram,
Right.
then you can follow that.
Right.
But for the average person in the street, you don't necessarily know that what they're picking up on their watch or other device actually is accurately AF. So you want to validate it in some way, in some prolonged monitoring with a high quality electrocardiographic.
So this has really become a problem, right? And not
well,
much data yet. So
yeah, but the companies would tell you it's a benefit, and I think there is a benefit.
I agree with them.
Yeah.
I think knowing you have AFib, you can at least have the discussion. But
Right.
So somewhere in the future, when we have actually some data published on this, we're going
Right.
to get you back here for part 2. But Daniel, thank you so
Okay,
much.
my pleasure.
Great,
Thank you.
Great information for the community. Thank you, Daniel.